Hello, we're group number 5 for Critical Appraisal, section 5A, and here's my group mates. So for our assigned journal, Hydroxyethyl starch or saline for fluid resuscitation in intensive care. So the aim of this study is to determine whether the patients in the intensive care unit who will receive fluid resuscitation with either 6% hydroxyethyl starch or saline have an increased rate of survival at 90 days. The trial was conducted in 32 hospitals in Australia and New Zealand, and investigators randomly assigned 7,000 patients who had been admitted to an ICU in a 1:1 ratio to receive either 6% hydroxyethyl starch with molecular weight of 130 kilodalton and a molar substitution ratio of 0.4 in a 0.9% sodium chloride or 0.9 sodium chloride saline for all fluid resuscitation until ICU discharge, death, or 90 days after randomization. The primary outcome was death within 90 days. Secondary outcomes included acute kidney injury and failure and treatment with renal replacement therapy. The authors compared times using log-rank tests and presented this as Kaplan-Meier curves. For the drug inquiry assigned to us, your ICU team was looking for a fluid type that can lower fluid requirements needed for resuscitation for a middle-aged adult being managed at the emergency department for septic shock. Emergency department consultant mentioned that they have floor stocks of hydroxyethyl starch and would like to inquire if the hydroxyethyl starch can be safely used as resuscitation fluid to lower the pressures and improve outcomes. So for directness, this is the question for the drug inquiry and a journal question that was assigned to us. So for the population about the drug inquiry, among adult patients admitted in emergency department with septic shock, and for the intervention is the hydroxyethyl starch or the HES. Comparative, there's none, and then for the outcome, lower pressures and improved outcomes. So for our journal question, the population among adults admitted in ICU requiring fluid resuscitation, then intervention same, 6% hydroxyethyl starch. Then there's a comparison, it's the 0.9% sodium chloride saline, and the outcome is to reduce the mortality at 90 days. So for our research question, among adults admitted in the ICU that requires fluid resuscitation, how effective is the hydroxyethyl starch compared to saline in reducing mortality for 90 days?
For appraising validity, for the question were patients randomly assigned to treatment groups, we answered yes. This is based on page 1901 where it says, we randomly assigned 7,000 patients who had been admitted to an intensive care unit in a 1:1 ratio to receive either 6% HES with a molecular weight of 130 kD and a molar substitution ratio of 0.4 and 0.9% sodium chloride, or receive 0.9% sodium chloride or saline for all fluid resuscitation until ICU discharge, death, or 90 days after randomization. For the question was allocation concealed, we answered yes. This is based on page 1903 where it says, study treatments were randomly assigned over an encrypted web-based randomization system with the use of a minimization algorithm stratified according to institution and an admission diagnosis of trauma. For the question, were baseline characteristics similar at the start of the trial? Yes, baseline characteristics were similar. There was no significant difference between the groups of the 6% HES versus the saline group, except for the central venous pressure and lactate levels. This can be seen on Table 1, where baseline characteristics of the patients were listed accordingly.
So for the question, were patients blinded to treatment assignment? We answer it yes, and this can be found on page 1902, and it states that the crystalloid versus hydroxyethyl starch trial, or what they call CHEST was an investigator-initiated, multicenter, prospective, blinded, parallel group, randomized controlled trial conducted in 32 hospitals in Australia and New Zealand. Next is where caregivers blinded to treatment assignment. We answered it yes, and this can be found on page 1910. And it states that the clinicians were unaware of study group assignments, which made it unlikely that the difference was caused by variation in thresholds for initiating therapy. For the question, were outcome assessors blinded to treatment assignment? This time we answered it no, as it was not specifically stated.
Were all patients analyzed in the groups to which they were originally randomized? Our answer is yes. This is according to page 1904. Trained research coordinators collected data at each site and entered them into a web-based database. Data monitoring and source data verification were conducted according to a pre-specified monitoring plan. An independent data and safety monitoring committee reviewed data from pre-specified interim analysis after the enrollment of 2,000 and 4,000 patients. We conducted all efficacy analysis on an intention-to-treat basis, methods for handling or missing data, and the reporting and analysis of adverse effects are outlined in the supplementary appendix. Was follow-up rate adequate? Our answer is yes, based on the figure, which we'll see on the next slide. Loss to follow-up for hydroxyethyl starch, or the HES group, was 185 out of 3,500 patients, or 5.29% dropout, and 164 out of 3,500 patients, or a 4.69% dropout, for the 0.9% saline group. Both groups are less than 20%, which is within the acceptable rate. Thus, follow-up rate is adequate.
Now for the appraising results. How large was the effective treatment? A total of 597 of 3,315 patients in the HES group and 566 of 3,336 in the Saline group died. There was no significant difference in mortality in 6 predefined subgroups. Renal replacement therapy was used in 235 of 3,352 patients in the HES group and 196 of 3,375 in the Saline group. In the HES and Saline groups, renal injury occurred in 34.6% and 38% of patients respectively, and renal failure occurred in 10.4% and 9.2% of patients respectively. HES was associated with significantly more adverse events. The safety and efficacy of hydroxyethyl starch for the fluid resuscitation have not been fully evaluated, and adverse events of the HES on survival and renal function have been reported. How precise was the estimate of the treatment effect? The primary outcome of death at 90 days in the HES group is higher than the Saline group. The relative risk value of 1.06. As shown in Figure 2, page 1908, the risk of death at 90 days runs across 1.0. Therefore, there was no significant difference in the probability of survival between the HES group and the Saline group during the 90 days after randomization. The 95% confidence interval indicates that 95% certain that the true value for the population lies within the range of 0.96 to 1.18. The CI is narrow, thus the precision is high. We can be confident in the result. Here we have the values for the following: relative risk, or the value of 1.06, relative risk reduction, of value of negative 0.06. The value for absolute risk reduction is negative 0.0104, and the value for number needed to treat is negative 96.
Appraising applicability. Are there biologic issues that may affect applicability of treatment? Yes, since participants are mostly from New Zealand and Australia, there's no representation of other races, which can be a problem. Age does not appear to be a problem, and as for comorbidities, those with impending or current dialysis-dependent renal failure, and those with evidence of intracranial hemorrhage on cranial computed tomography were excluded. This can be found on page 1902. Are there socioeconomic issues affecting applicability of treatment? Yes, the major issue would be the cost, since hydroxyethyl starch is associated with an increased relative risk of death and acute kidney injury, which can result in the need for renal replacement therapy.
For the individualizing results, first question, what is the likely effect of the treatment on your individual patient? Estimate the individualized NNT for your patient. For this, the number needed to treat is negative 96. Note that a negative number needed to treat indicates that a treatment has a harmful effect. An NNT of negative 96 indicates that if 96 patients are treated with the new treatment, one fewer would have a good outcome than if they all received the standard treatment. Additionally, evidence suggests that there is no appreciable difference in 90-day mortality between individuals who had saline or 6% hydroxyethyl starch resuscitation. Next question, would you offer the treatments to your patients? Possibly not, since 90 days randomization shows no significant difference in the probability of survival between the HES group and saline group. In addition to this, the use of HES lead to increased rate of renal replacement therapy. More studies regarding hydroxyethyl starch or the HES as a resuscitation fluid are warranted.
For conclusion of journal, in conclusion, our study does not provide evidence that resuscitation with 6% hydroxyethyl starch as compared with saline in the ICU provides any clinical benefit to the patient. Indeed, the use of hydroxyethyl starch resulted in an increased rate of renal replacement therapy. Thus, the selection of resuscitation fluid in critically ill patients requires careful consideration of its safety, its potential effect on patient-centered outcomes, and its cost. Next is the conclusion based on appraisal. In this trial, use of starch-based fluids like 6% hydroxyethyl starch within 90 days do not provide a mortality benefit and lead to increased renal dysfunction requiring renal replacement therapy. Starch-based fluids should not be utilized for volume resuscitation in critically ill medical and surgical patients. Therefore, the use of hydroxyethyl starch as a resuscitation fluid to lower pressures and improve outcomes is not recommended. More studies regarding hydroxyethyl starch as resuscitation fluid are warranted.
And that concludes our critical appraisal report. Thank you for listening.